All right, good morning, everyone. For those of you who I haven't met, my name is Jimmy Bowen. I'm one of the pediatric chief residents, and I have the pleasure this morning of introducing Dr. Wendy Chung. Dr. Chung, MD, PhD, is a clinical and molecular geneticist and the Kennedy Family Professor of Pediatrics and Medicine and Director of Clinical Genetics. She received her BA in Biochemistry and Economics from Cornell University, her MD from Cornell University Medical College, and her PhD from the Rockefeller University in Genetics. Dr. Chung directs NIH-funded research programs in human genetics of pulmonary hypertension, autism, birth defects, including congenital diaphragmatic hernia and congenital heart disease. She's a national leader in the ethical, legal, and social implications of genomics. She leads the Precision Medicine Resource in the Irving Institute at Columbia University. She's authored over 500 peer-reviewed papers and 75 reviews and chapters in medical texts. She was the recipient of the Medical Achievement Award from B'nai Alam, the New York Academy of Medicine Medal for Distinguished Contributions in Biomedical Science, the Rare Impact Award from the National Organization of Rare Disorders, and is a member of the National Academy of Medicine and the American Academy of Physicians. Dr. Chung enjoys the challenges of genetics as a rapidly changing field of medicine and strives to facilitate the integration of genetic medicine into all areas of healthcare in a medically, scientifically, and ethically sound, accessible, and cost-effective manner. Please join me in welcoming Dr. Chung this morning.
Thanks, Jimmy. I'm really pleased to be here this morning. Sorry I couldn't be here in person, but very glad to be here virtually. Let me make sure that can see my screen. So I'm going to go through ways of being able to scale genomic medicine. And I say that very intentionally in terms of thinking about how I've spent a lot of my time doing things on a small scale, but thinking about how we can do them on larger scale for children so that we can have more children get access and get a diagnosis so they can get onto their treatment. That's kind of the punchline in case you have to leave early or you fall asleep. So within this, I deal a lot, as many geneticists do, with rare diseases, rare genetic diseases specifically, but I'm going to make the point that although individually rare, they're collectively extremely common. And so to the extent that we can find ways of being able to do this for one condition, we potentially can scale this for multiple conditions. So keep that in mind as we're going through. Within pediatrics specifically, rare diseases are obviously even more of our practice, for instance, than it is for some of our adult colleagues. And that's unfortunately because many of those children may not make it to be adults. And so we as pediatricians spend an awful lot of our energy, whether we realize we're treating a child with a rare genetic condition or not. And I'm going to sort of explain how we can get to the point of making sure they get those diagnoses. The last point I want to make is that right now in the United States, it's taken way too long for patients to get a diagnosis. And I hope I'll give you a couple examples about how we can change that. I will say many people never get a genetic diagnosis. And again, as we get towards more specific care, more precise care based on the specific etiology or reason for the condition, that'll become increasingly important. So I'm going to go through and show several different use cases. I'll do it relatively quickly, but I'm going to highlight sort of the clinically relevant details. And if people have questions about a lot of the science and some of the data behind this, I'm glad to share it. But I'm going to give you sort of the high level overview of this. So I'm going to start, and this is going to be a theme through three different examples I'll give you. But I see a lot of patients with congenital heart disease. I know many of you do as well. Common condition, 1% of all of our births have congenital heart disease, and obviously significant care and resources go into caring for those individuals. I also see many of those patients prenatally because we increasingly do ultrasounds, echocardiograms in terms of preparing for when that child is born. And within that, I commonly get asked the question, so Dr. Chung, the cardiac surgeons, the cardiologists tell me that they'll be able to repair the plumbing, so to speak, repair in terms of holes or connections. But tell me, how's my child's going to do when they're 20 or 30? Are they going to be living independently? Are they going to have any other medical difficulties? Are they going to go to college? Are they going to, what kind of life are they going to have? And is there anything that I can do importantly to allow them to have the best life? What can I do? The parents want to be empowered. So they want to know what they can do to assure that their child is going to live, is going to be healthy, and is going to be happy. And so Within this, there are questions from the cardiologist as well. Which of these children with congenital heart disease am I going to have to worry about with developing pulmonary hypertension, as an example, something I spend a lot of time thinking about? Which ones are going to have difficulty with ventricular function or the squeeze of the heart and may need to go on, for instance, to a heart transplant later in life, because although we fix the plumbing, there are still inherent intrinsic problems to the heart that's remaining in terms of contractility, or arrhythmias, or there are electrical problems inherent to the heart, not scar tissue from the surgery, but inherent electrical problems. So with all of those issues, we also ask the question from the cardiac standpoint, what can I do to tailor my surveillance and perhaps planning in terms of that child long-term? One of the biggest issues, which I'm going to get to in my third example, is not just the heart, but the head. So in those cases, we can, again, think about what the heart's going to do. And it's not about cyanosis with a congenital heart disease. It's not about bypass times, but is there inherently anything different in the head for those individuals? Or in other words, is there a difference in terms of the way the brain is functioning? And if that's the case, can we help? Can we, with early intervention, with knowing about specific things with attention, executive function, other related conditions, can we help those individuals by early recognition, in contrast to sort of letting it arise and then dealing with the frustration because you didn't realize that child was struggling, for instance, from an educational point of view, because of something that was just inherently different in terms of the way their brain was working. So with all of those things, we've been trying to get to greater specificity. And again, that's going to be a common theme. And to the extent that we know a specific genetic diagnosis, we can help with some of that specificity, at least in terms of guiding surveillance and support, and perhaps someday in terms of actual treatment for those conditions. Again, that's going to be a ways off, but perhaps later. So within this, we have a large study, and I'm going to emphasize large in scale over and over, something called the Bench to Bassinet program that's part of the Pediatric Cardiac Genomics Consortium. This is an NHLBI funded study or from the National Institutes of Health. And we've gotten together with many institutions and at this point studied about 15,000 individuals with congenital heart disease. And as we've done that, we initially took or thought about the following thing. So think about someone who has, for instance, hypoplastic left heart syndrome. A decade ago, those individuals, in large part because we didn't have the advances in terms of CT surgery or cardiac care, those individuals for the most part, did not live to grow up, to be able to reproduce or have their own children. And so when you think about from a population genetics point of view, those genes, where were they? How did they come about? Those genes were not passed down from one generation to the next. That is because those individuals either died or did not have their own children. Those genes would not have been passed on. And so early on, when we started this, we had the hypothesis, and again, this is over a decade ago, but we had the hypothesis that many of these types of genetic events that affected what we call reproductive fitness or the ability to have children and live to the age of childbearing, that many of those would be due to de novo or new genetic mutations. They were not inherited from the mother or the father, but they started brand new in child. And from a population genetics point of view, they arose new every single generation. And that's going to be a theme again that I'm going to come back to. So when we did the first analyses, we did a comprehensive genomic analysis in the day we did exome sequencing. We now do genome sequencing. And on average, for any one person, they have approximately 1 to 2 coding, so in other words, affecting amino acid and proteins, coding changes within their genome. So it's not a very large number, and it allows us to narrow the search space quite a bit by just focusing on those de novo genetic variants and the ones that are affecting the coding sequence. And when we narrowed the search space and looked at that, we could see that number one, everyone has those de novo changes, so it's not exclusive to individuals with congenital heart disease or any other major structural anomalies. everyone has them, but there are certain ones that fall in particular genes or certain types of genetic variants that are deleterious or have a bad effect in terms of those genes that are disproportionately enriched in individuals who have, I'll tell you about congenital heart disease or diaphragmatic hernia or autism. I'll go through those 3 examples today, but those seem to be enriched in those individuals. Again, those de novo deleterious variants in those genes in particular that are expressed while those organs are developing. So as I said, if you look at controls, and again, looking at these de novo variants that are deleterious, everyone has some of them. But when you look at all individuals with congenital heart disease, there are more of them in individuals with congenital heart disease. And now if you start to split out across different types of congenital heart disease, we see some in isolated congenital heart disease, but many more in individuals with congenital heart disease, plus another congenital anomaly. If you also look at congenital heart disease plus neurodevelopmental disorders and compare it to isolated congenital heart disease, again, there are more of them there. Even more if you look at congenital heart disease plus other anomalies plus neurodevelopmental conditions. And many of us recognize those as patients with syndromes. They appear to have a lot going on, and perhaps not surprising that there might be one gene that has many effects in terms of the way the body functions as well as the way the body forms. So that was kind of the first clue that there might be some signal here. And we would have to drill down to find out specifically what genes and what that signal is. I'm going to go through and skip a lot of steps in the middle, but to say that as of now, 2022, we can now look at individuals using our most advanced genomic technologies, and that includes, for instance, either chromosome microarray and exome sequencing or genome sequencing as one test. And we can look at individuals with either isolated congenital heart disease or this complex congenital heart disease, or what I was calling syndromic. In other words, having more than one congenital anomaly or problems with growth or problems with development. And as you look at them, you can see the diagnostic yields ranging approximately 20% for isolated and approximately 40% for complex. Now, that still means we don't know, or I will tell you, we don't know everything. I think this is the floor in terms of that diagnostic yield. I think that could actually be higher because we don't yet know how to interpret all of that information and we don't recognize everything. If you break it down, and I won't go through, again, a lot of detail here, but I want you to notice that in gray are also inherited genetic variants. So in addition to these various different types of de novo variants in yellow, orange, and blue, there are also inherited variants that contribute as well. And I'll be getting into that just a little bit more. But that's, I think, part of what's going to increase in terms of what is unrecognized currently. When we do that, as I was alluding to, and this is work that Matt Lewis has done with me, a cardiologist in our group, we can see that this information, these de novo genetic variants, also tell us about ventricular function long-term. So if you look at serial echocardiograms or MRIs, for those that have what we call likely pathogenic in this sort of pinkish color here, compared to non-likely pathogenic de novo variants, we see increasing in terms of abnormal function, worsening function over time, or as I was saying, arrhythmias. Now, this doesn't give me the specificity yet to say exactly who is going to have those issues, but we can see this group sort of signal in terms of the aggregate compilation of all those with likely pathogenic variants. And so the next step is really to get to figure out there's more in the individuals with this type of variants, but exactly which individuals are going to have those challenges. So we're now getting to the point for individual genes where we can have specificity. I won't claim that we're finished with this, we're just starting, but I wanted to give you a couple examples. So this is one particular gene, PAX1. It's at the one extreme in the sense that, and this is with permission from these beautiful families and children, this is one of our family meetings for PAX1. With this, every single child on the right that you can see over here has the same exact genetic variants. It actually is remarkable for its homogeneity. They're all de novo genetic variants, but they're all exactly the same change. They're associated with septal defects that are usually relatively easy to manage, but again, they're associated with a specific neurodevelopmental pattern that if we know about this, we can help to support those children early on to help get them the resources they need for success. At the other extreme, in terms of this is now an inherited genetic variant, GDF1, which is one of the genes that we know of, is associated with autosomal recessive, and in this case, isolated congenital heart disease. So at the other extreme, we know this is the heart. It's only the heart. It's not associated with other issues. I will say that from this, we've identified, again, a single founder mutation in the Ashkenazi community. And now, and I'm in New York, so I have a fair number of Ashkenazi Jewish patients. When I look at patients with transposition of the great artery or double outlet right ventricle, in fact, I almost exclusively see this exact gene in this exact variant. And so it's now allowed me to much faster come to a diagnosis. I oftentimes don't need very fancy testing, and we can help reassure those individuals that we need to manage the heart, but we don't need to manage the head in these particular cases. And so that's, again, helped to provide reassurance and guidance going forward. It's not only the heart, as I was alluding to, that we can make some predictions on, but again, similar to as I talked to before with these likely pathogenic de novo variants, we see increasing issues in terms of neurodevelopmental issues. And as I was talking about with PAX1, greater specificity in terms of not just that there will be issues, but what types of issues will there be, and potentially how can we support those individuals early on. So now that you know the general sort of paradigm, I want to just say that it's not just congenital heart disease. I also study another congenital anomaly called congenital diaphragmatic hernia. I know many of you are familiar with this. I will say that as a resident, I was taught the paradigm at that time was that when this diaphragm was not formed correctly during fetal development, you had the abdominal contents that would herniate up into the thorax, and you'd get compression of the heart and the lungs over to the other side. Most oftentimes this is on the left, so it would be pushing things to the right. And it was thought that this compression effect was really affecting alveologenesis or development of the lungs here. And so that with that, that was really where a lot of the problems were coming from, because long-term, the mortality of this is often associated with pulmonary hypertension and or problems in terms of aeration or pulmonary issues. And so, the thinking was that this was part and parcel in terms of compression. Punchline, that's not really entirely the case. In addition to that, I know from following many of my CDH patients long-term, like congenital heart disease, they can have other associated both medical and neurodevelopmental problems. And in fact, even though the diaphragm may be easily repaired, those issues may persist. And so in a similar way, we started looking at those with likely pathogenic variants. And just to say that in orange here, when you compare those with the genetic aspect versus those without, there's an enrichment or greater mortality for those with the genetic aspect as well. So that's something that we see with mortality. We also see it in terms of pulmonary hypertension. Again, much higher frequency of pulmonary hypertension at 1 month of age. Although again, you still see it in those without it. If you break it out into those that appear to be complex congenital or diaphragmatic hernia versus isolated, the point I want to make is you see much greater difference here in the isolated cases. So the genetics seem to be driving it, a greater difference, at least in the isolated cases in particular. I won't go into all the complexities of this, but we also follow these children as they're growing up from a developmental point of view. So the first time we see them is at 2 years of age to evaluate development with a Bayley scale of infant development, a standardized way of seeing how those children are developing. And if we take into account all the factors that could be affecting cognition, again, you can see that those in terms of the genetic portion of this, the genetics, again, to the left is showing that it's having a negative effect. 0 here is the line of unity. The genetics and likely pathogenic variants are having a strong effect in terms of the cognitive part of Bayley as well as the motor part of the Bayley scale. There are also other factors as well. So oxygenation at discharge or oxygen requirement also, which I think is giving us an overall sense of how rough the clinical course was, ECMO, but not something like, for instance, the pulmonary hypertension. So we can start to now tease apart what are genetics and what are non-genetic factors. As we're doing this this, we can get down to specificity in terms of individual genes. And as we do that, I'll just point out that one of the genes we've identified is LONP1. It actually accounts for about 3% of children with diaphragmatic hernia. It's the most common genetic cause that we know of these days. And now what I want us to show you is what we do to try and tease these different things apart. So go back to what I said before. LONP1, I thought might, or again, diaphragmatic hernia, I thought might be problems with lungs secondary to compression. So in a mouse, we can tease these things apart. And so with our collaborator, Jin Sun, we've been able to express a knockout of LONP1, but only in the lung. In other words, we can keep the diaphragm intact, we can keep the head intact, we can have the expression of the knockout or take out the gene only in the lung and tease out each different organ system separately. So in these mice that have an intact diaphragm that have knockout of LONP1 in the lungs, you can see that the lungs, even grossly, if you just look at them, look different, look smaller. You may be able to see there's some additional cysts here. Again, if you look at it more carefully, you can see that the organization looks different. You can see these big sort of cysts here. Again, seeing the cysts here, and now under the microscope, you can see how deranged the lung development actually is. Again, with an intact diaphragm, suggesting to me that this is a primary problem with lung development in addition to a primary problem with diaphragm development. And of course, there can be a double whammy in terms of both deranged development and compression, but suggesting that there are some conditions which are primary problems with lung development. The reason I bring this up is because some of you may have seen the paper in the New England Journal of Medicine looking at fetal esophageal tracheal occlusion. So in other words, the fetal surgeons think about being able to occlude the airway during development, during fetal development, potentially allowing greater expansion of the lungs and perhaps then more normal development of the lungs. What I would posit, although this is just a hypothesis, is that, and we know this, not everyone responds to FeTO, and in fact, FeTO can be associated with premature delivery. There's a risk associated with it. So importantly, in terms of trying to decide who are the best candidates for something like that, trying to weigh the risks and the benefits, I would posit that by knowing, for instance, if this were someone with a LONP1 variant, the relative benefit versus the risk is probably different than someone who doesn't have any of those genetic factors. And so again, it's a hypothesis yet to be tested, but how can this help us in terms of more precise management as we do that? So doing this is helpful, I think, but needs to be tested rigorously. And folks like Stephen Kingsmore have done an amazing job in terms of doing this. And one of the things that Stephen Kingsmore did was to think about the time frame. That is, that if this is going to help us, let's get this information sooner rather than later. And in particular, if we've got very sick infants in our intensive care units, let's get that information quickly. I'll also say that with Ron Wapner and several of my colleagues, we also have a study, an NIH study that looks at this prenatally. So we have something called prenatal seq to be able to do this type of whole genome sequencing on parents, on the fetus, to get this information before the baby's born, hoping that that allows us to make a smooth transition postnatally and have our teams informed of the details of these diagnoses so they can give the baby the best care possible. But if we don't do this prenatally for whatever reason, that's fine. We do have the opportunity to postnatally. I'll say that we do this in our intensive care unit at Columbia as an example. We've gotten the turnaround time to 6 days, still not quite 24 or 48 hours, but 6 days is not bad as we're doing it. And as we do that, our diagnostic yield at this point is running about 30%, specifically in the series with infants with congenital heart disease. Shown on the right are some of the diagnoses that we've made in this particular group. All of these known to be associated, although very different prognoses associated with different conditions. And being able to do this helps us in terms of giving better support, both during the hospitalization, but even more importantly, when the baby's being discharged home. As we do this, I think one of the benefits has been that we can have the multiple consultative services meet the family before discharge. helping them to prepare for that smooth transition, being able to make sure the baby has, the parents especially have this sort of idea of the overall care of their child, and not feeling like there's a lot of back and forth. We get better communication in our teams when we can do it while the baby's there, while the parents are there, and kind of have the baby packaged up, so to speak, and on a good trajectory. And so that's been, I think, one of the biggest benefits in terms of doing this early. With this, as I said, we can have many cases. In fact, all that I'm showing on this screen are due to de novo genetic variants. I will say that one of the things I've seen from the families as we've returned this is this sense of actual relief in some ways that it is de novo. Many of them are concerned about whether it'll happen again in a future pregnancy. And so I think we can be reassuring about that. There's still a very small chance it can happen again. And we even have ways of addressing that. Which if anyone has questions I can talk about later. But in terms of doing this, also this relief of guilt. I'll say the mothers especially oftentimes have some concern about was it something they did or didn't do during the pregnancy, and being able to absolve them of this guilt very early on, I think helps them to create space in terms of just focusing on the things that matter. It also, I think, helps in terms of clearer communication to the families about prognosis. Everyone gets on the same page faster in terms of what we need to do. And I think with seeing it kind of in black and white in the DNA takes away some of the ambiguity, makes it very concrete. I will say that with that, it is important to support the families from a psychosocial point of view, because some of them can, it's an adjustment, and being able to support them through that adjustment is important. And our social workers, our genetic counselors are very helpful with that. As I started doing this, and this is, I'm going to show you the columns. These are columns over here for genes on the left and groups of genes. Here is congenital heart disease in the middle that I started talking out with. Here's diaphragmatic hernia on the left, which I just mentioned. And then here are a group of conditions that are in the head. So intellectual disabilities, autism spectrum disorder, neurodevelopmental conditions over there here on the right. One of the things I want to point out, though, is that many of these genes, or some of these genes, have overlap. So you'll see for these genes in particular, some of them can be seen in all of the conditions. Many of them, in fact, can be seen almost always with some sort of neurodevelopmental issue, and then with less frequency with congenital heart disease or diaphragmatic hernia. Some patients will have all three of these conditions in one person. In other cases, they may have one or the other. But I also want to point out there are some genes, for instance, some of these transcription factors, where you don't see neurodevelopmental issues. So it becomes important, as I said, to tease these apart and to be able to know which conditions are associated with which things. And so I think over time we'll get greater specificity. This association made me wonder, especially about the heterogeneity of autism. So some people know me as thinking a lot about autism, just like congenital heart disease. It's quite diverse in terms of differences. And so we even put that in the name, autism spectrum condition or disorder. And it is very, very variable. And so many parents, especially when their child is diagnosed at 2 or 3 years of age with autism, are wondering what that trajectory looks like for them. And again, wanting to support them. With this, the genetics can be helpful. I will say it's the return in terms of the genetics is about 10% in terms of finding a genetic diagnosis with our currently available methods. So it's still modest in terms of doing that, but we wanted to make it better. So I started this study. We actually just celebrated our 5th anniversary, a study called SPARK, and this is now the scaling part of things. So this is Simon's Foundation Powering Autism Research for Knowledge. This type of study is different in many, many ways, and I hope is an example for the future, but an example of scale. We now have, as of this morning, over 280,000 individuals across the United States in this study, over 107,000 individuals with autism, and then the rest are their parents or their other family members. As we did this again, the idea is that there's heterogeneity under the label of autism, and that if we have greater specificity, it'll help support individuals better. But to do that, we currently estimated there are at least 500 different genetic subtypes of autism. And to be able to power that from a calculation, a statistical calculation, you need at least 100,000 individuals with autism to be able to get to these subtypes. And identify all of these subtypes. So it's big. It's really a large study. Within this, the other part that we did very differently is that we, from the very beginning, brought the autism community to the table to help us design the study, think about the important questions. And every single day within this study, we have either individuals with autism and or their family members who are integrated into our staff, into our advisory boards, into our community advisory council, into our diversity, equity, and inclusivity boards. All things are infused with individuals from the community to make sure that everything we do in terms of the questions, how we do research, how we take that research back to the community, everything is within the context of being of the community, for the community, with the community. As we're doing this, this is a US-based study. We also wanted to make it easy for people to participate and be inclusive. And so that included being online as well as 31 clinical sites around the country, and to be able to do this literally any time of day, doing it in your jammies at 10 o'clock at night after the kids are in bed, or however you needed to do this to be able to meet you where you were. The only requirements is a professional diagnosis of autism, and for anyone who'd like to find out more, the website is shown here. And all of this information, let me underscore, is with appropriate IRB approval, freely available to the entire research community. So we wanted to power autism research for everyone. This is not something, this is really a core resource for the community. As we've done this, we have something that's called Research Match. And so this is also an unabashed advertisement for anyone in the audience who might do autism research. You can use this as a way of recruiting for your studies. So we have 4 times a year, quarterly review of applications for these. And it's meant to be able to help you to do your research better. These are just some examples of the research studies that have come out of Research Match. And then what we do is, as researchers learn, we have them provide that information back to our participants in the form of monthly webinars, as well as newsletters and research reports, so that the community is learning together with us. And this has been especially important, I'll just say, during COVID. We were able to, on a dime, 2 months into the pandemic, start to study the impact of the pandemic on specifically the autism community, which was especially important, as you'll recall, because we suddenly went into social lockdown, which for individuals who have at their core social issues and social communication issues, really had a very different impact on our community than it did, for instance, for other conditions. I won't go too much into the detail, but to say that with such large numbers that we have, and Spark also includes a genetic component. It's not exclusively a genetic study, but it does include a genetic component for those who want to participate. We've been able to look at both de novo as well as these inherited variants that I was alluding to. I won't spend a huge amount of time going into the details, but just to say that as of now, we've identified approximately 100 of the genes, as well as copy number variants that underlie autism. There's still more to come, but you can already see that there's a lot of heterogeneity, and we're making significant progress inward. When it comes to de novo genetic variants, we realize that these overlap quite a bit with genes that have also been identified from researchers as causing intellectual disabilities or cognitive issues. And in fact, about 70%, or about 2/3 of those de novo genetic variants, are attributable to known genes for intellectual disabilities. On the other hand, there are also inherited genetic variants, and those inherited genetic variants are a different group of genes for the most part. Those are not genes really that are primarily intellectual disability genes, but others that have other sort of effects in terms of brain and brain function. So let me just give you an example. In red on the right here is shown de novo genetic variants. In blue, those that are inherited, and these are different gene names. Don't worry so much about the individual gene names, but you'll see that for some genes like MED13, it's mostly de novo variants, as opposed to some other genes like NAV3 or ITSEN1, really a large number of inherited variants as well. And when it comes to these inherited variants, and as we start looking at the parents with these same variants, we're realizing that it's not exclusively autism, that in fact there are other neuropsychiatric conditions that can be associated with this in parents, other things that have to do with the full spectrum of learning disabilities, social anxiety, psychiatric manifestations. But we see that this is really broader effects on the brain and brain function, and probably due to specific circumstances of life, may manifest in slightly different ways. And so getting into this, I think this study is not going to be just one about autism, but really thinking about mental health wellness overall. And so I hope this will be important things we can learn and diffuse in other ways. I have a sister study that goes with Spark called Simon's Searchlight. So within Spark, one of the things we do is to return genetic results to participants if they're in one of that 10% where we find a diagnosis. I think that's very important to give back to our community. And with this, we try and do it very responsibly. So those results, again, nationwide, those results are returned, believe it or not, either through me or more importantly, through a staff of genetic counselors who are centrally located and able to return these to participants. Again, we do this through a confirmation, a CLIA confirmation, so a double check in doing that. And then as these individuals go along their journey, we now plug them into a specific community just for their genetic condition so that they can learn from each other. As you can imagine, there are a lot of these communities. So these are the genes that are in that community. And this community is now sort of powered by individuals coming in through Spark, as well as individuals who get a diagnosis anywhere in the world. And it doesn't have to be associated with autism, but could be associated with other problems, intellectual disabilities, epilepsy, other types of neurological conditions. And they are usually diagnosed through clinical testing. So they're seeing a doctor, a neurologist, a geneticist, doing that testing, and then invited to join our study here. Some of the genes are larger just based on frequency or based on the number of members in the community have decided to join. And then this information, again, freely available to the research community, as well as developing resources for researchers, including things like induced pluripotential stem cells, as well as in some cases funding to support the research that's done. In terms of that research, we really realize we're at the very beginning of this, but we're starting to understand natural history for these conditions. As I said, starting to develop reagents like induced pluripotential stem cells, in some cases animal models, and different groups are in different positions, but some starting to now be able to try different treatments, in some cases small molecules, in some cases folks are trying ASOs, even gene therapy. None are over the finish line yet, but they're thinking about doing this. And most groups, I would say, are in the sort of determining disease mechanism and developing strategies, but with the hope that at some point it will get to preclinical trials, clinical trial readiness, and then clinical trials. Just to show you an example of one of these patient groups, this is one for a condition called KIF1A. This is a molecular motor. I'm showing you here our first family meeting in 2017. You can see what a small but mighty group we were. Just 2 years later, how much larger the group had been. And again, this isn't everyone, just the people who were able to attend in person. This was our last in-person family meeting due to the pandemic, but online we've grown to now over 400 individuals within our community for this one condition. This is just a movie showing you what this gene does. It's a molecular motor in neurons. And so this is a dimer, I don't know if you can see it, but 2 copies of the protein wound together. This is a microtubule along an axon in a neuron. And this right here, this big ball is the cargo. So this is the motor that's responsible for walking down the microtubule and transporting this cargo. And this is actually sort of a common thing across several different conditions we now study. I'll show you in a second, but the mutations that we see for this condition are largely in these feet that you see here, and the contact that's made between these feet and then the microtubule. And then there's a pocket here which hydrolyzes ATP to make the energy that's necessary, is another hotspot for mutations. The condition itself is extremely heterogeneous. This is just a stick figure of the gene itself, and this is the motor domain. Those are the feet that I was showing you in the last movie. And each one of these dots represents a person within our registry. And within this, you can see that in some cases, for one specific amino acid, we may have independently many, many different individuals with that same amino acid affected. For other circumstances, we may just have one single person. Over time, the numbers are increasing, but you can see that this is incredibly heterogeneous. And with this, heterogeneity in terms of the severity. We now have some really elegant ways of studying the microtubule in action. So we literally can watch in terms of how quickly that motor moves. We can see if it falls off the microtubule. We can see if it stalls or it goes sort of starts moving and then freezes and gets stuck. And within this, we can make correlations between how the microtubule works and then how clinically we see the manifestations. Those manifestations could be as mild as spastic paraplegia, so a peripheral neuropathy that doesn't affect longevity, to, in the more severe cases, individuals who die by the time they're 4 or 5 years old due to a very, very severe encephalopathy and epilepsy. And so we have the full spectrum. This is in particular a condition that's heart-wrenching to me because it's degenerative. That is, individuals deteriorate over time because these axons are not able to function properly. We lose neurons over time. I'll get back to that a little bit later, but it is degenerative and probably one way in terms of the degeneration. So the families are quite impassioned in this. They have a hashtag stop the clock because they are really so relentless in terms of trying to move things forward to prevent the degeneration that we're seeing. I'm going to go relatively quickly, but to say that one of the things about genetics is that it is not static. We're not at steady state yet in terms of understanding. All the examples I've given you today are things that I'm very excited about, but we have not finished learning. And so one of the other scalable things we've been thinking about is how do we continue, once we've ordered a genetic test clinically, for instance, if we end up with something that's uncertain, that's not resolved, that's not clear cut, or we don't have an answer, how do we continue learning over time? How do we resolve ambiguities? How do we resolve variants of uncertain significance to get those families to the point that they have information they can now start to use? I won't have time to get into it today, but I do think there are system changes that we can make. I do think that in terms of having an electronic health record, this is a key in terms of being able to scale the things that we can do. I'll just say that in very brief in terms of illusion, and I can go into that later. But I hope that we'll get to, again, using that as infrastructure, a highway, and then have some nodes of specialty care or specialty expertise that we can use in terms of dissemination, both to, I'll point out on the right, both clinicians, and they don't have to be genetic clinicians, but all clinicians, and then also patients and their family. I think as patients have access to my chart and direct access to their information, they can also be used to help us together. As we do this, part of the reason I say this is that one of the things many people have is Epic, and I'm not plugging Epic. I have no vested interest in Epic, but it does have a large part of the market share in terms of healthcare IT. And so as we do this, we have at Columbia a Nord Center of Excellence. And one of the things that, I think through these nodes in terms of healthcare systems we're trying to do is think about how to take best practices forth for rare diseases. And again, have systems of communication, systems of verified information that we can use for dissemination. Things that are, for instance, best practice alerts or BPAs, decision support that can pop up and be able to disseminate as we learn new information. And I'll give you an example. Just very recently, a medication was FDA approved for achondroplasia. Very, very specific in terms of the age that it's useful. We've got a window of basically 5 to about 15 you can think about. So we don't have forever to use this medication. And again, I have no potential sort of stock in this. I have no financial interest in this, but it's important to identify those individuals with achondroplasia and get that information out to them, get that information out to their physicians, because there's a limited time in terms of treatment. Increasingly, I hope that's true of other genetic conditions, and we need to have those highways to identify those patients, get the word out, be able to tell them about that opportunity. Again, I'm not dictating care, but simply in terms of an awareness about what can be done. So as we're doing this, that helps if you know the diagnosis. So for achondroplasia, if you know your diagnosis, that's great. If you don't know your diagnosis, though, you've got to get to the starting line. You've got to get that diagnosis to be able to then act on that information as those treatments are available. And so we're also thinking about how can we recognize by looking looking in the EHR, by looking for patterns, by looking for specific clinical features that can be converted into things that we call HBO terms, or things that are kind of a standard nomenclature to identify individuals that have a higher probability of having a genetic diagnosis, and then tapping a clinician on the shoulder. Again, not mandating care, but saying, you know what, there's something that might be helpful to this patient. Might you want to make a referral, for instance, to a genetic colleague? Might you want to be able to raise awareness in terms of those possibilities? And I have to say, practitioners, especially primary care practitioners, they're so incredibly busy, and they're dealing with COVID oftentimes for a lot of things, that sometimes this gets lost in the shuffle. And so again, trying to be supportive in terms of getting those patients to a diagnosis. Getting to a diagnosis, as I said, because it's increasingly, I'm realizing that for some of these conditions that might seem very common, we may have specific molecularly targeted therapies. So I'll take a common condition of obesity, problems in terms of being overweight, where I personally started my scientific career. From work that we and others did, we identified specific genetic rare subtypes of obesity, and they included leptin receptor deficiency, pro-opiomelanocortin deficiency, and I won't go into all the scientific details except to say that we realized that there were centers in the brain, in the hypothalamus, that were responsible for hunger and for feeling satiated, and therefore driving food intake behaviors. And part of this, in terms of the output, was through the melanocortin-4 receptor. And you could, and if you have a mutation that destroys the function of this, this was the most common genetic risk for obesity. You could, on the other hand, flip that around to say that if you could have an agonist for the melanocortin-4 receptor, have that signaling constantly going through, you would feel more full. And as you felt more full, you decrease your food intake and hopefully decrease your weight. And so this is not my work. And again, I have no financial interest, but a company came up with setmelanotide as that medicine that would be that melanocortin-4 receptor agonist. In doing that, and this is data that's been published now for POMC, or pro-opiomelanocortin deficiency, this is showing what happens in terms of hunger, and then weight, hunger in red, weight in this teal color. And this is the period here of treatment. And you can see hunger immediately just plummets. Weight comes down, obviously takes more time to decrease weight. This was a period when the drug, by study design, when the drug was stopped, and you can see things rebounding back up, but then starting again on the open label extension, and you can see them coming down again. And in fact, this has now been FDA approved based on some of these data, and it's now been extended to other genetic subtypes of obesity. And I won't sort of give away the punchline for this, but watch and see in terms of what comes out in terms of where it is and maybe where it's not effective. But with this, it then becomes a motivation to understand from a genetic point of view what perhaps could be a genetic form of obesity, in particular as pediatricians, for those with early onset or very severe obesity. So let me be now even more provocative to say that as I've been thinking about this, I've been thinking about scalability and equity, and make sure that we leave no one behind as a pediatrician. And so I started thinking about this with a condition called spinal muscular atrophy. It used to be, underscore past tense, used to be the most common genetic cause of death for children less than 2 years of age. It comes in terms of different subtypes depending on the number of copies of a gene called survival motor neuron 2. But again, type 1 used to be universally fatal unless we put people on a respirator. And even with that, oftentimes fatal after some period of time. It had the benefit of being 95% of mutations being due to an exon 7 deletion in the gene survival motor neuron 1, which allowed me to think about how we might do a screen that we could do on scale. And so I started thinking about this just at the time clinical trials were starting for what is now an FDA-approved medication, Spinraza. What I started thinking was we could use the blood spots that we take for newborn screening, do a very targeted test for this common mutation, identify these babies. And what's key on this is that, like KIF1A, this is a degenerative condition. And once you lose those, in this case, these motor neurons, it's a one-way street. You can't get them back. And so it was important to me to identify these babies pre-symptomatically, before we had any evidence of motor neuron loss, although there could have been, even in these few days this until we made the diagnosis, but do it as early as possible and do this on scale. And so as we did this as a consented pilot study in New York State. It's starting in 2016. It was quite successful. We identified babies that then went into the clinical trial. It was up to them whether or not they decided to do that. But this was the first baby that was identified from our newborn screening pilot, went into that study very quickly. And this is a home video from her showing some of her first steps. She is strong. She would have had type 1 SMA, the most severe type, as I described to you, like I said, most children don't live to see their first birthday. She's strong. She doesn't have respiratory issues. And in fact, really went on to show both the ability of newborn screening to work, and we now have 3 different FDA-approved treatments, including a one and done gene therapy. And in fact, as a result of this little girl and others in this study, we now have universal, or at least it is on the recommended universal screening panel for newborn screening to do SMA screening throughout the country. We're not quite there with implementation, but we are on the road now with the majority of babies, newborn babies, being screened. So with this, just to be provocative, I think that newborn screening story can work for other conditions as well. I think it's especially important where early intervention is key, but I do think we have lots of opportunities to scale what we're doing in terms of screening, to be able to diagnose conditions early, even if it's not screening, if it's at the point of diagnosing, help to make sure more of our kiddos can get that diagnosis so that we can get onto the supports and the treatment that are going to help them be their best. The challenge, I think, is to do this equitably, to make sure that everyone has access in terms of doing it, and then to be getting treatments available for all these individuals. That's where our biggest gap is at this point, but hopefully where we're going to have many more opportunities in the future. So let me just say that there are a lot of funders that make all this work possible, a lot of incredibly important people, both in the laboratory, at the Simons Foundation, that help get all this work done, and of course our participants and our families, for whom we do everything that we do. So I thank you, and I'll be glad to take questions.
While people think about their questions, I can start us off, Dr. Chung. For patients that you see with perhaps no outright dangerous symptoms, like for example, with less of a concern for congenital heart disease, but maybe a concern for autism spectrum disorder, sometimes I found that parents are a little bit less willing to go through genetic testing because they think, like, what effect is this going to have? Is there a specific way in your experience that you find success in counseling families with that?
Sure. So number one, not everyone's the same, right? And I'm not going to be the genetic sort of police here saying everyone must get genetic testing. We must, look at everyone's genome from soup to nuts, start to finish. It's an individual decision. So I always ask the question, what's in it for me, right? So why do I want to know about this information? So one question parents often ask is, if they're thinking of having other children, is it going to happen again? Do I have any possibilities in terms of making informed decisions, reproductive decisions? That's their individual decision, but that can be quite helpful these days. And if we can find a genetic diagnosis, we can help them if there is a high chance it'll happen again, or to reassure them that it's not likely to happen again. So that's number one. Number two is the prognosis question. So many parents are asking about that trajectory, that prognosis, what can I expect? And I think those are two of the most sort of common reasons that are in terms of being able to answer that. Just realize that if we don't find a genetic diagnosis, it's not a guarantee it's not genetic, because we still don't know everything, but it helps us to be able to get better estimates of things. I think it's helpful. I personally do this all the time as I'm talking to families to say, what's the likelihood I'll find an answer? Just take autism, as you were saying. When I see autism with intellectual disabilities, I have a much higher chance of finding an answer than if I have, what some people will call Asperger's, or someone who's on the milder end of the spectrum. And so, being upfront and honest with them about that. They're often, an important factor for them is it covered by insurance? If this is something covered by insurance and it's not a big financial expenditure, they would say, absolutely, this is information I want, but otherwise maybe it's not something that financially I can afford right now. The other factor in terms of treatment, actually, cure, I'm going to, dare say I use that word cure. For most individuals, we don't have cures right now. So I'm very clear with parents about that. It's not, most cases are not like SMA where we've got a one and done gene therapy to do this. When we do have it, it becomes all that much more important that we get that information out. But like I said, if there's something where it affects a medical decision to use do a treatment, not do a treatment, I'll give you something as mundane because I was thinking about last night as I was talking to a family that I diagnosed with Williams syndrome. With the diagnosis of Williams syndrome, it affects what we do in terms of anesthesia and what the anesthesiologists do. And so even though that might be, hopefully something that is not going to be an issue, knowing that about that in advance and being able to prepare for that, to me, is an important thing for the family and for the health of my patient.
That's very helpful. Thank you. I think I see Dr. Broccoli has his hand up.
I do indeed, and it looks like they're going to let me actually ask it, Wendy. Hi, great talk. Thanks for agreeing to do this. It is, the idea of rapid turnaround genetic testing in the critically ill newborn and in our congenital heart disease patients has really changed the landscape, and I have been looking or thinking more about how we branch out from here, and so the obvious places are to go next to the pediatric ICUs, then the adult ICUs, but I also wonder about using genome data that we collect early on for what I've been calling age-appropriate screening. So it's great if you can identify things in the newborn period, but if you don't, if it's not something that you need to do anything about until age 10, you don't really want to unblind the families to that. And the same thing with age 20, 30, and 70. Have you? How do you re-access your genomic data in older children if you feel like it's necessary?
Right. Jerry, that's a great question, and one I've thought a lot about. And so let me try and rephrase this in a certain way. So what Dr. Bockley's talking about is that when you get your genome, right? And so you get your genome in terms of what you were looking for. You also get your genome in terms of things you weren't looking for. So whether that might be, for instance, a BRCA1 mutation predisposing to hereditary breast and ovarian cancer, but not for, could easily be 25, 50 years, right? And so what do you do with that? So it gets complicated in the sense of we've thought about all sorts of things. Do you give it to someone on a cloud account? Do you give it to them on their drive and they're responsible? Like you put it in the participants' hands. Most of them don't know what to do with that. And when I think about from an equity point of view, are we doing this in an equitable way if we do that? I will say, and I'm happy to talk to you later about this, in short order, I think it's a family-specific decision, and it's just complicated. What I tend to do in my own personal practice is when I'm in that acute setting, in the hospital, when in the intensive care unit, all of those secondary findings or that extra stuff that's not related to the indication, I actually table that discussion. I don't include that, or I offer it to the patients, but I strongly encourage them not to think about that right now. Keep your eye on the prize in terms of what we need for that management right then. It's a very emotional time for them, and I just, and most of the families follow my advice in terms of doing that. What I do then is I come back to them at 6 months after that, when hopefully things have settled down. I will say it's challenging because they don't always settle down, and some babies will die. But I come back to them later when they're just in a different state of mind in terms of doing that. And then I'll ask them if they want some of that additional information. And I will say it's been challenging. I'll just give you one specific example, is when it comes to that hereditary cancer, I'll oftentimes find it not only in the child, but I'll also find it in one of the parents. And I often feel like the parents need to know that to take care of themselves, even though the child doesn't need to know the information at that point. And so it's a complicated discussion. And I do that with the parents in terms of, do you want to know this for yourselves? Do you want to know it for your child? I'll try and disentangle those two issues and help them to think through it, and then have them make that decision at that point about what they really want to do. But that's where I think genetic counselors especially are helpful in terms of thinking 3 steps ahead, having seen the experience of what that can do in terms of families. And from some studies we've done of adolescents, and specifically in the hereditary cancer and cardiomyopathy space, I'm very cognizant of how adolescents are thinking about this, and it's complicated for them. They think they know what they're doing, and sometimes they do and sometimes they don't, is just what I'll say. And I think that just comes with adolescence and growing and maturing. So complicated answer. I do think there are technological solutions, but I'm worried that in some cases that may be harder. And when some of those children get to be adults, another solution that some people advocate for is it's going to be a different world by then. Just let them address it as adults. Kind of don't worry about it now. Worry about where the state is going to be when they're adults. And at that point, you can gate it based on what they need from a developmental point of view with a new test. So I hope I gave you some ideas, although perhaps not the definitive answer.
Thank you, Dr. Chung. For now, there are no further questions in the chat. A few people thanking you for your very exciting talk. And for those listening in today, there is no meet and greet or Q&A session. But if any questions come up, feel free to contact Dr. Zuckerbraun, Colleen, or myself, and we can help connect you.
Thanks for having me, Jimmy. Bye-bye.